gospodo. Ja vas sve najljepše pozdravljam u ime našeg ravnatelja, doktora Mittermajera, ravnatelja Agencije za kvalitetu i akreditaciju u zdravstvu i socijalnoj skrbi. Najljepše se zahvaljujem organizatorima na pozivu za suorganizacijama ovog okruglog stola na temu procjene zdravstvenih tehnologija. Također najljepše pozdravljam naše drage goste, stručnjake iz inozemstva, kao i naše sudionike okruglog stola koji su se odazvali našem pozivu. Vi znate da i već jučer ste čuli uvodna predavanja, izvanredno predavanje profesora Kristensena, profesora Michaela Drummonda i vidjeli ste koliko je važna procjena zdravstvenih tehnologija za racionalizaciju zdravstvenog sustava i za daljnje učinkovito donošenje odluka u zdravstvenoj politici. Naš cilj ovog okruglog stola koji će biti podijeljen u 3 bloka. Prvi blok govorit će naši međunarodni stručnjaci, dakle sa nacionalne perspektive, perspektive Francuske, zatim sa europske perspektive. Drugi dio će biti prikaz naše nacionalne, znači Agencije za kvalitetu i akreditaciju u zdravstvu, Odjela za procjenu zdravstvenih tehnologija. Također prikaz i osvrt Ministarstva zdravlja i Hrvatskog zavoda za zdravstveno osiguranje. I treći blok, vrlo važan, znači važnost, uloga, problemi i kako ih riješiti. Dakle, učesnika, dionika, važnih stakeholdera u procesu procjene zdravstvenih tehnologija. Prije nego što počnemo, ja bih željela ispričati, ispričali su se dvoje sudionika okruglog stola, to je dr. Sambunjak u ime Ministarstva zdravlja i doktorica Vera Vlahović-Palčevski u ime kliničara, dakle važnih dionika u procesu procjene zdravstvenih tehnologija. Uz njihovo dopuštenje ja ću prikazati samo nekoliko slajdova kako bi vidjeli važnost uloge kliničara i perspektivu Ministarstva zdravlja na proces procjene zdravstvenih tehnologija u Hrvatskoj. Dakle, krećemo sa prvim blokom. Ja ću prvo predstaviti naše uvažene goste i stručnjake iz inozemstva. Profesor Kristensen je predsjednik izvršnog povjerenstva i direktor sekretarijata Europske mreže za procjenu zdravstvenih tehnologija EUnetHTA. Od 1999. godine on je profesor sveučilišta Južne Danske. Od 1997. do 2009. bio je direktor Danskog centra za procjenu zdravstvenih tehnologija ZDRAVSTVENE. On je liječnik specijalist obiteljske medicine i javnog zdravstva s doktoratom znanosti iz epidemiologije. Od 80. godina sudjeluje u mnogim međunarodnim projektima na području epidemiologije, HTA, kao i kliničkih smjernica. Od 2003. do 2006. bio je predsjednik međunarodne mreže za HTA i NAHTE i voditelj EUnetHTA projekta 2006. do 2008. On je i urednik poznate knjige o HTA, član je Britanske savjetodavne grupe za HTA od 2005. godine, a od 2010. godine član znanstvenog vijeća Health Economic Research Center iz Luksemburga, te je predsjednik znanstvenog vijeća Austrijskog Ludwig Boltzmann instituta za HTA od 2007. godine. Naš drugi uvaženi gost, dr. Francois Meyer, je liječnik specijalist endokrinologije i bolesti metabolizma, radio je dugi niz godina u nekoliko kliničkih bolnica u Francuskoj, a od 1992. do 1997. u farmaceutskoj industriji kao voditelj grupe za onkologiju. 1997. postaje zamjenik direktora za medicinske poslove francuske agencije French Health Product Safety Agency, a od 2000. do 2002. član je povjerenstva Orphan Medical Products pri Europskoj agenciji za lijekove. 2005. godine pridružuje se novoosnovanoj javnoj neovisnoj ustanovi French National Autorite for Health, popularnom HAS, kao direktor odjela za HTA, a sada i kao savjetnik predsjednika vijeća HAS-a za međunarodne poslove. Ja lijepo molim doktora Meyera da krene sa prikazom, dakle, nacionalne perspektive sa perspektive Francuske, a dalje će nastaviti profesor Kristensen i profesor Meyer sa europske perspektive. Hvala.
Thank you very much, Mirjana, for this kind introduction. Thank you for the invitation. I'm very pleased to be here to this very interesting and meeting. My first talk will be about the French situation about HTA, and then I'll come back to explain what we do in the cooperation, European cooperation, that is very important in our eyes. So first, let's go with the French example. That's the outline of my presentation. I will introduce my institution, then the HTA processes within my institution, focus a bit on drugs, and then talk about the current changes and the prospects we have about HTA. So, what is the National French Authority for Health, or Haute Autorite de Santé, HAS? It was set up in 2005 as a part of a reform of the healthcare system, and it has more than 400 staff, and has the expertise of a very huge number of external experts. And it is now the single institution for HTA in France. I mean, we are the institution that advises public decision makers on all questions related to the basket of healthcare products and healthcare interventions. So for drugs, but also medical devices, procedures, screening policies, and so on. So we have a broader remit, not only HTA, also a remit in clinical guidelines, in quality of care with hospital accreditation, with certification, and the quality of the professionals, and so on. So that's a broad missions, and we try to have an integrated approach. So not when we work for the HTA assessing health technologies, we try to combine this assessment, for instance, with an update of a clinical guideline and with the definition of the best healthcare pathways for patients with chronic disease for which the drug is indicated, for instance. So we try to have an integrated approach, taking advantage of our broad missions. But of course, that's not always easy. So I'm not going into detail for the organization charts. Let's just say that at the head of HAS, we have a board of 8 members. It is an independent institution. We are not under the authority of the Minister of Health. So these members of the board are nominated for a 6-year term, and nobody can fire them. You have to change the law if you want to change the member of the board before the end of their mandate. And we have 2 main divisions, one on HTA and the other of actions on quality and safety in healthcare. So basically our mission is on evaluation, recommendation, and also on accreditation and certification, all of them contributing to have the best possible quality for healthcare in France. So we work with specialist committees that are composed of external experts of HAS, but are chaired by one of the members of HAS board. As you can see, among these 7 specialist committees within HAS, 3 of them deal with HTA. One on pharmaceuticals, one on non-drug interventions, and the third one on economic evaluation and public health evaluation. So, Haute Autorité de Santé is an advisor, as it is the case for HTA. We are not decision makers, but we advise the several decision makers, the Ministry of Health, to advise on public health policy and also on reimbursements. A pricing committee that I will talk about later, the CEPS, for which we advise our advice is used for the pricing committee to set the price of a new drug or a new device. And of course the National Health Insurance Funds. We are also, of course, in close relationship with the stakeholders that I have put above, with the pharma and medical devices companies, and also the Union of Health Professionals, and of course the patient associations. We are closely associated to them to give our advice. And the Parliament had just a role to oversee how the system works, and Haute Autorité de Santé reports to the Parliament send its activity report to the Parliament. So what are our processes? First, HTA has to be flexible in those days. We started in France by doing mainly rapid HTAs. In the UK, they were doing, our colleagues from NICE were doing mostly full HTA for new drugs. And we can see that now NICE has put in place the rapid HTA processes that are more and more important. And in a symmetric way in France, we are now implementing more and more full HTA reports. So we have either to ask to a limited number, give advice on a limited number of points and items for a rapid HTA that has to be done within 90 days according to the European regulation, or we can do a full HTA that will look into all the domains of HTA that Finn will explain later. So we deal with various questions, some public health issues, where we have in every case to look at all the domains of HTA, because it's not only a matter of efficacy of public health measure. For instance, should we set up an organized screening policy for a given disease? That's something that has to take into account all the domains that could be ethical, of course, always economical, and so on. For example, we gave advice on the setup to organize a national screening program for cervical cancer, for HIV screening strategies, and so on. So that's something that is full HTA with economic outcomes. For procedures, we assess both diagnostic procedures and therapeutic interventional procedures. And we have not only the task to assess the new procedures, but also to reassess the ones that have been used for quite a long time, because some of them may be obsolete or maybe not used in the best way, and we have to update the assessment for existing procedures. And that's something that is general for all the health technologies, but particularly for procedures. Medical devices as well, we can do rapid HTA for new medical devices that want to be reimbursed. They have to go through HAS first, and we also review the classes of medical devices that have been on the market for a long time. Then we have set up a new policy a couple of years ago for innovative diagnostics and procedures, that is a coverage with evidence development. We have a temporary coverage decision with a limited and restricted use in a little number of hospitals. With additional evidence generation, it means that all the patients that get the technology have to go into observational studies, to be included in an observational studies. And then we will review after the end of the temporary period and take into account all the other data we have, including the data from the observational study, and make a final decision. The first example for the use of this new process is about TAVI, the transcatheter aortic valve implantation, for which we had a temporary and limited diffusion of the technique, and then a reassessment with the help of the new data. So reassessment of technologies is quite important. It is mandatory on a regular basis for drugs and devices. It can't be more than 5 years between one assessment and a reassessment. But it can be done at any time when new data, significant data are available. It can be done in the view of a possible disinvestment, and in the late 90s and the early starting between 1999 and 2005, we had reviews of all categories of medicinal products, and the first assessment in 1999 was that among the more than 4,000 drugs that were reimbursed at that time, there are less a bit now, more than 800, that is about 20% of them, should be delisted because there was no sufficient data to justify that the community, the society, pays for these drugs.